Soft tissue manipulation. Prague has always fascinated visitors with the beauty of her natural surroundings and the dignity of her many historical buildings of all architectural styles and periods. But Prague is also a city with remarkable modern buildings, like the Motol University Hospital with its many departments.
The motor system consists not only of bones and joints and muscles, but also of soft tissues surrounding them. Soft tissues can be compared to an infrastructure without which the joints and muscles cannot function. For obvious reasons, these structures have to adapt to every movement. They must therefore be elastic. They can shorten and lengthen and even shift one against the other. This function of the soft tissues is widely underrated and frequently not even noticed or exactly examined. While this is taken for granted, the joints move and muscle contract. The fact that soft tissues also move is not taken into account. Yet the skin, the subcutaneous tissues and the fascia all have to move in harmony with joints and muscles. They have to lengthen, to shorten, and they are as mobile as the joints and the muscles.
Soft tissues can move considerably during trunk flexion and extension, for instance, where changes in the length of the skin can be measured. We can demonstrate how during contraction and decontraction the muscle moves against the bone, no less than joints move. You can see this movement during contraction and decontraction of the biceps. It follows that we have to diagnose and treat not only dysfunction and muscle spasm or trigger points, but also soft tissue changes. This is not simply a mechanical question, it is due to reflex action. The barrier phenomenon. There is a characteristic feature common to all these changes, something like a common denominator. It is disturbance of the protective barrier. First described in joints, the significance of this barrier can easily be demonstrated. However fast we extend the elbow joint, there is never hard impact at extreme range. The joint is protected by a physiological barrier. Our diagram shows the anatomical barriers A and A, which are protected and never reached, while the clinically important range of movement goes from pH to pH, the physiological barriers which determine the range of movement under normal conditions. This clinical concept corresponds to what we find by palpation. Under normal conditions, the resistance of a joint at mid-range is negligible. Therefore, the smallest resistance found on palpation is the first signal for us to engage the barrier or to take up the slack. If pressure is only slightly increased, the range of movement will increase too, and we can spring the barrier. The diagram shows a typical disturbance, the pathological or restrictive barrier path, limiting the range of movement. It differs in quality from the physiological barrier, being abrupt and springing much less. It is this change in quality which is most readily felt at palpation. The pathological barrier can even cause a change of the neutral point from N0 to N1, producing asymmetrical movement. The barrier is important not only for diagnosis but also for therapy. After engaging the barrier, the therapist can wait and obtain release, normalizing the physiological barrier and restoring function, and as a rule relieving pain. Once release has started, it continues spontaneously until the normal physiological barrier is reached, without our significantly changing pressure or pull. The therapist must sense how long release lasts and never stop sooner. The skin. The first structure on which we will demonstrate soft tissue techniques is the skin. First, we diagnose hyperalgesic zones. Stroking with our fingers, we examine skin drag. In a hyperalgesic zone, there is increased resistance or friction, skin drag, due to perspiration. In a hyperalgesic zone, the skin fold is thicker, in this case on the left, and the skin offers more resistance to stretch. After engaging the barrier, we can spring it and compare it with the normal side of the body. This must be done in the same direction on each side. On the restricted side, we again take up the slack, and after a short latency, we obtain release. Skin drag, stretching, and folding are then normal on both sides. Hyperalgesic zones in the interdigital folds of the hands, and especially of the feet, are of great significance in root syndromes, when pain radiates as far as the fingers or toes. In such cases, the interdigital fold resists stretching and springing in the corresponding segment. That is to say, in the root syndrome L5, between the first and second, and between the second and third toe, and in the root syndrome S1, between the third and fourth, and the fourth and fifth toes. In the hand, the interdigital fold between the second and the third and fourth fingers corresponds to root C7, and between the fourth and fifth fingers to root C8. These are reliable neurological signs of spinal root involvement. After engaging the barrier and obtaining release of the pathological barrier, we can frequently improve radicular pain syndromes. Stretching a fold of connective tissue. We now turn to connective tissue structures in the subcutaneous tissue and the muscles. The structures most frequently involved are scars and the connective tissue of taut muscles. On the right, I can bend the patient's head towards the shoulder. This is normal. On the left, though, I meet resistance due to a short upper trapezius. An active scar shows a superficial hyperalgesic zone as well as a thickened fold of deep connective tissue at its most active part, which is tender on pressure. Treatment consists in forming a fold and stretching it with minimum force, never pressing, until the barrier is reached. We now have to wait 10 to 20 seconds for release, or even more, the longer the better. For better fixation, we reinforce one thumb with the other. We must sense release the whole time, so as not to interrupt it. The direction of stretch is then reversed, and further release follows. The thickness and tenderness of the fold are then checked. This technique is very useful for short muscles. In this patient, we are dealing with the upper trapezius. We make a fold of muscle tissue, Then the slack is taken up and we wait for release. The advantage of this method is that stretch is not carried out in the direction of the muscle fibers, and therefore there is no risk of stretch reflex. The direction of stretch is now reversed, and after engaging the barrier we again wait to obtain release. It is advisable to reinforce one thumb with the other. After treatment, the two sides are compared. If a very large muscle such as the hamstrings is taut, it cannot be stretched between our thumbs. We have to use the palms and fingers of both hands. Treatment is applied in both directions. Treatment by pressure alone. In certain situations, mere pressure can be effective, in particular at the site of trigger points in muscles close to the surface, like the erector spinae. We palpate for trigger points, which feel ropey. Using very little force, we engage the barrier, and release follows. During release, resistance melts as our finger sinks deeper into the tissue without our increasing pressure. Now we just stabilize our thumbs on the trigger point and wait for release until the physiological barrier is reached. We palpate the trigger point again and see that the patient no longer feels pain. In a large muscle, such as the gluteus maximus, we have to change the direction of pressure after obtaining release in one direction, as there can be pathological barriers in other directions as well. If pressure can be applied by a pincer movement between two fingers, as to the sternomastoid, we again obtain release by minimum pressure, sensing the resistance melt away between our fingers. There should be no more pain. Fascias. The fascias appear to be the most important of the soft tissue structures. They enable muscles to move freely during contraction and decontraction, in particular against bone. It is obvious that if this mobility is impaired, neither muscles nor joints can function normally. This is particularly the case in the chronic stage. It is important that movement restriction need not be on the side where pain is felt. The contrast between the two sides is known as the tight-loose complex. We treat the restricted side in order to restore symmetry. This figure shows muscle fibers merging into the fascias on the back and the abdomen. The mechanism by which the fascias affect the functioning of all muscles concerned.
Fascie ovlivňuje veškeré svaly, které do ní přecházejí.
Fascias on the back. For diagnosis, the patient is prone with the head in a neutral position and the arms alongside the trunk. We examine the mobility of soft tissues against bone in a cranial direction, take up the slack and spring the barrier, and then compare the two sides. In our patient, mobility is restricted on the left. For treatment, the patient lies prone with his head turned to the left, turned to the side we will treat. The arm on the same side is fully extended, and so are the fingers of that hand. The toes on the foot of the same side press against the end of the table. The therapist fixes the fascia with one hand and mobilizes with the other. After the slack has been taken up, the patient inhales and we obtain release during exhalation. Breathe in, breathe out, and cough. Breathe in, breathe in, breathe out. This maneuver can be repeated 2 or 3 times. You can see that the therapist's hands are now further apart. If we wish to restore mobility of fascias and muscles in a caudal direction, we first compare mobility of soft tissues on either side in a neutral position and spring the barrier. The patient lies in the same position as for treatment in a cranial direction. The main difference is that we now begin with exhalation, creating increased resistance, while release is obtained during inhalation. Breathe out, breathe out, breathe in, breathe in, breathe out, breathe out, breathe in. This is repeated 2 or 3 times. You can see that now the therapist's hand move further apart. It is important to diagnose restricted mobility of the buttocks in a cranial direction with a typical pathological barrier. We move both buttocks in a cranial direction, taking up the slack and springing the barrier, comparing the 2 sides. Here you see restriction on the right. For treatment, we engage the barrier in a cranial direction and wait for release. Fascias on the side of the trunk. The fascias on the trunk can be stretched for examination and treatment. We support one side of the patient's trunk with our knee. On the other side, we side bend his raised arm and his trunk, fixing the pelvis from above with the other hand to engage the barrier. For treatment, the patient presses his elbow against our hand, looks up and breathes in, breathe in, breathe in, look down and breathe out. Release is obtained during exhalation. Stretching the fascias on the side of the trunk is very effective in self-treatment. The patient stands with legs apart, thus fixing his pelvis. With one hand he grasps the other elbow and pulls his trunk into lateral flexion, engaging the barrier. He then resists the pull by looking up and breathing in, holding his breath, and then looking down, relaxing into lateral flexion. He repeats the maneuver, breathing in and again stretching while breathing out. This is repeated several times. The patient can stretch one side of the neck, the upper trapezius. Sitting, he grasps the end of the table with one hand, fixing his shoulder. The other hand reaches over his head, and bending sideways, he takes up the slack. Looking up, he breathes in and holds his breath, increasing resistance. Then he looks down and breathes out, relaxing into lateral flexion. Fascias round the thorax. In chest pain, in particular in women with mastodynia and in patients with trigger points in the subscapularis, movement of fascias at the chest is often restricted. Mobility of the soft tissues must be examined on both sides, round the axis of the trunk, noting any asymmetry. We treat the restricted side, engaging the barrier. The patient breathes in and release occurs on exhalation. Fascias round the neck. The soft tissues and the fascias of the neck can be moved by rotation round the axis. If on engaging the barrier and springing we find restriction, we engage the barrier again, and after the usual latency, release is obtained. You can see how the tape on my thumb moves. We have now reached the physiological barrier, and as we check the soft tissues, you can see increased mobility and springing is restored. We can examine the cervicothoracic area with both hands, either by a rotatory or a wringing movement. This is also the method of treatment. We can engage the barrier by a rotatory movement followed by release, or by a ringing movement, first in one and then in the opposite direction, waiting at the barrier to obtain release after the usual latency period. Fascias at the extremities. For diagnosis and treatment of fascia dysfunction in the upper extremity, we use a rotatory movement round the long axis of the arm. For diagnosis, we engage the barrier and spring it. For therapy, we engage the barrier and wait to obtain release. This may be done above the elbow, at the elbow, on the forearm, and round the wrist. Each time we reach the barrier and wait for release. If we use a ringing movement, the barrier is engaged and release obtained first in one and then in the opposite direction. Diagnosis and treatment of the lower extremity follow the same pattern, applying a rotatory or a ringing movement, engaging the barrier and springing, first at the thigh, followed by the knee, the leg and the ankle. For treatment, we take up the slack and wait for release. In the case of the ringing movement, always in both directions, engaging the barrier and waiting for release. The scalp. At the head, the role played by fascias in other parts of the body is assumed by the scalp, including the skin over the forehead, nose and cheeks. Normal mobility is of great importance. Movement restriction is related to disturbed function in both the cervical and the cranial region. Pathological barriers play a part in headache and in vertigo. Here too the procedure is similar to that in other parts of the body. Mobility is palpated and the slack is taken up. Here you see normal mobility on the right, while on the left mobility is restricted and there is hardly any springing. After engaging the barrier, you can now see that our fingers move further. Take care not to let the fingers slip over the hair. While engaging the barrier and springing, we must pay attention to symmetry. After treatment, the range of movement and resistance to movement are checked. You can see that now the scalp shifts normally and we can spring the barrier. The heel. There are two types of pain at the heel, one originating at the calcaneal spur, where the plantar aponeurosis is attached, the other at the posterior edge of the heel, the attachment point of the Achilles tendon. In the first case, we have to examine mobility of the soft tissue pad at the heel by pressing our fingers, engaging the barrier and springing it, again engaging the barrier and springing it. If we find a pathological barrier, we engage the barrier and obtain release by pressure. If pain is felt at the posterior edge of the heel, it may be related to a painful Achilles tendon, in which case it is caused by a trigger point in the soleus, which is treated by post-isometric relaxation. The pain may, however, be due to tenderness of the soft tissue between the tendon and the bone. In this case, we form a soft tissue fold between the tendon and the bone. It can be sprung for diagnosis. Then we take up the slack and obtain release, repeating the procedure in the opposite direction. It is technically important to place our thumbs so as to find enough room between the Achilles tendon and the bone. Metatarsals and metacarpals. Mobility of the metatarsal and metacarpal bones, one against the other, depends not on joint function, but on the soft tissue between these bones. This mobility can be considerable. In root syndromes with pain radiating to the toes or fingers, we find increased resistance between these bones which can be treated. This is a phenomenon similar to the increased resistance of the interdigital fold against distraction, which we mentioned earlier. This is a specific neurological sign of a lesion of the corresponding nerve root and localizes it. For examination, we grasp two adjacent metatarsals between the thumb and forefinger of each hand. To take up the slack, we produce a dorsal shift. Spring them one against the other, following up with a shift in the plantar direction. For treatment, we use a pincer movement, exerting pressure on adjacent metatarsals with both thumbs in a plantar direction and both forefingers in a dorsal direction, to take up the slack and obtain release after a short latency. The position of the fingers is then reversed. We take up the slack, and after engaging the barrier, release follows. Examination and treatment of the hand is carried out in a similar way. Mobility of individual metacarpal bones is examined in a dorsal and then in a palmar direction, grasping two adjacent metacarpals between the thumb and forefinger of both hands, engaging the barrier and springing. For treatment, we use a pincer movement, engaging the barrier and obtaining release, first in one and then in the opposite direction. Painful periosteal points and epicondyles. Painful periosteal points are another frequent sign of myofascial pain. They are most frequently found at the attachment points of tendons and ligaments. Here we examine the mobility of subperiosteal tissue in various directions, in the case of the epicondyles at the elbow. We find movement restriction of overlying soft tissue with pathological barriers in at least one direction. Here our usual technique is applied, producing release and relief of pain. Spinous processes. It is typical for a tender spinous process that one side is much less tender than the other. In this case, tenderness is much more pronounced on the left than on the right, and tissue tension is also much greater there. We place the finger next to the spinous process on the right side to take up the slack by pressure and wait for release. The tip of the finger is stabilized between the thumb and the forefinger of the other hand. As tension vanishes, we see the tip of our finger sinking into the tissue. We wait until there is no more movement and then check up. A tender periosteal point is very frequently found on the lateral aspect of the spinous process of the axis. Patients often call it a painful bruise. To examine, we side bend the head, producing axis rotation, to make palpation easier. This is followed by examination of mobility of the soft tissues in all directions at the pain point. You can see that we have now found the direction of restriction and that the barrier does not spring. The other side is then palpated for comparison. We now know where and in which direction to apply treatment. We engage the barrier and wait the usual latency period to obtain release. Our fingers move in the restricted direction. When movement has stopped, we check tissue mobility and tenderness. You can see that we have restored mobility in all directions and the patient no longer feels pain.
Tak co, už to tak nebolí?
Už to dobrý.
Another frequent pain point is found on the spina iliaca posterior superior. We first examine the mobility of subperiosteal soft tissue on both sides for a pathological barrier as well as for tenderness. You can see that mobility is restricted in a lateral direction on the left and that there is hardly any springing. Treatment therefore follows the same direction. After engaging the barrier, we obtain release and wait for our finger to stop moving. Then we check for mobility and pain. The pes anserinus. In the leg, the pes anserinus tibiae often harbors a typical pain point corresponding to spasm or trigger points in the adductors. Here too we examine mobility of the soft periosteal tissue and spring the barrier. Treatment follows the direction of movement restriction and the pathological barrier. After treatment we check for mobility and tenderness. You can see that mobility has now improved and that the barrier springs normally. This treatment of periosteal pain points is painless because we only restore mobility of the overlying soft tissue, avoiding pressure on the pain point itself.
The soft tissue techniques, which are the subject of this film, have greatly widened the scope and possibilities of manipulative therapy. They enable us to give specific treatment to every structure related to the motor system. They are non-invasive and very gentle, and they are performed with our own hands. The great advantage of our hands in comparison with all instruments is that they sense what they do. We are therefore in a diagnostic situation that is in a feedback situation with our patients.